And let me share my screen first, so we can get started.
Perfect.
Okay. It is so smart to have automatic subtitles underneath. Okay, let me remove that from there. Okay. I am Jaehoon Lee. Let me introduce myself. And I am a medical informaticist at Intermountain Healthcare. And I'm also an adjunct professor of University of Utah, Department of Biomedical Informatics. I have been here in Utah for the last 10 years. I'm originally from South Korea. And my supervisor, Stan Hopp, we have been mentors and supporters of Korean medical informatics research and our friends over there. And by that, we were asked to do this interview with interoperability expert. I don't have any conflicts of interest to disclose. Can you briefly introduce yourself?
Sure. I'm Josh Mandel. I'm a physician and software engineer. I'm the chief architect at Microsoft Healthcare and for an open standards effort called Smart Health IT, and have generally been working on health data standards and authorization standards, both for individual access and to help clinicians access health records. I've been in this space for about a decade, and I've had the pleasure of working with Stan for a good chunk of that time.
Excellent. Thank you. Next slide. I designed this interview to be 25 to 30 minutes, and you are the fifth person. And previously, so far, none of the previous interviews have done this interview on time. So it's probably my fault to have to design
It's
this
an
interview a
ambitious
bit
schedule.
longer than that. Yeah, they are great experts and their knowledge are just overwhelming. But I brought up 5 questions and they are all kind of open and huge questions. So you don't have to necessarily, I would suggest to bring all of your thoughts for each of those questions, but would rather a little bit shorter version of answer first because those questions overlap. Then we will have final, last minutes to cover all of this. And if we are missing anything, then you can cover that in the end as well.
All right, it sounds good. We'll give it a shot.
Okay. About the organization, the agency doing this research is KHIS. It's Korean Health Information Service. It's pretty new organization under HHS in Korea, but you might consider this organization as Korean ONC because see this list of programs and projects they're doing are quite similar to what ONC is doing. They have EMR certification program and HIEs and healthcare data standard support and things like that. And they have a lot of interest in interoperability and FHIR and standard vocabularies. Specifically, this project, we started this project just for 6 months period, but we would like to get some, understand the state of the art of healthcare IT and interoperability and electronic health records to build a nationwide framework for electronic health record and standards. And we have collaborators, including probably most of the major hospitals in South Korea, Samsung Medical Center, Asan and Seoul National University Hospital, and etc. And what I was assigned and favors to do is do this interview with interoperability expert. And we would like to do benchmark best practices from other countries and experts and host interviews with this interoperability experts to cover their knowledge and insight and lessons learned from the subject like Smart on FHIR, CDS hooks, and FHIR implementations, and even further interoperability governance and the role of interoperability stakeholders. It's quite broader level of interview with me. But we have reviewed and brainstormed to derive 5 key questions. So let me start from the first one, which is in the area of governance. So question is this. Everybody's saying that, yeah, we have to do interoperability or we have to do data standardization. Good. But there are multiple stakeholders associated quite in a complicated way, especially in healthcare world. And it's hard to say that, okay, who would like to roll up sleeve and jump into the problem, or who would like to pay and invest and lead innovation to solve the problem and boost interoperability. Sometimes it's not quite clear. And South Korea, you don't have to necessarily familiar with our country's situation, but we are a country based on a single payer system, and we speak Korean, and culturally quite unique, and geographically small. Territory-wise, it's smaller than probably Utah, but we are based on well-developed IT infrastructure. So what do you think that how do we invest in interoperability, and which of those stakeholders could be governments or vendors or researchers or practitioners to lead this innovation?
Sure. I mean, so the way that I think about this, interoperability is a means to an end. It's a way to, connect components together and get something done. But in the overall healthcare structure that you're listing here, like the actual value of doing any work, that value is increasing the health of populations or individuals, or making people happier or making their jobs easier, right? So like interoperability might be a small tool to help get that done. And so the best projects are ones where there is some overarching, motivating, and financially valuable goal, right? So maybe this is something like better treatment of chronic conditions, where you're going to help people live longer and healthier lives. Or it could be something like a learning health system, where you're going to improve the scientific endeavor by feeding information from healthcare back into the research and discovery process, right? So those things are the valuable goals that can actually, deliver to society. And the way that I think about it, to do any of those projects means having the right collection of stakeholders. These are all engagements that take government, the technology sector, the healthcare sector, individual consumer advocates, science and research. It's a whole mix. Okay. All those have to come together to get a project done. And for me, the mindset should be, anytime we're embarking on a project like this, let's try to include technology that's going to work not just for this one project, but also for the next couple of projects that we can see coming down the line, so we don't wind up building the same infrastructure over and over again. So rather than thinking about it from a how do we develop an interoperability infrastructure perspective, I tend to think about it from a, here's the projects that we're doing. Let's adopt the pieces of technology we need for these projects, but do it in a forward-looking way.
Okay. Yep, that's great view from the perspective. And would you think that, you are the first person so far in this interview series, a person from industry, and there are other interviews we recruited from industry. That would you think that there might be some, what would be the gaps between the way of from industry's view to seeing interoperability, as opposed to whereas the other views from governance or researchers or hospitals or providers?
So I'm kind of an odd duck from industry, because my focus really is not on commercial products and services. I sit within the research side of Microsoft, and I'm really focused on working with the standards and interop community on technologies that are going to be of broad use. But I'll just say very briefly, one of the big tensions, particularly at large technology companies, is how much do you build in an industry specific way? So technology that's designed for healthcare or for finance or the automotive industry, versus how much do you sort of invest in these horizontal platforms that can be shared infrastructure across all of them? And that's kind of a classic tension.
Oh, okay. Yep, that sounds reasonable. Yep, to me. Okay, thank you. We will cover governance or in the for the rest of the questions as well, because like I said, these are huge questions, like my overlaps. Let's just move on to the next question, role of FHIR. So it's amazing and impressive that FHIR has been growing and expanding to a variety of use in healthcare. What do you expect the role of FHIR in the future interoperability, and how can, you're from industry and you're a physician, But from government perspective, how can we well support it?
So I see, the FHIR standards that were developed, first to help individual systems talk to each other. That's kind of the interoperability use case. How do I share lab results or medications or allergies between a healthcare provider here and an insurance company there, or a patient app here and a research study there? That's kind of the interoperability use case. But more and more, we see application developers and startups digging into FHIR and using some of the core data models for many other purposes, including as kind of an app platform to say, well, my app needs some kind of data storage and needs to be able to process many different data types that are relevant for healthcare. Rather than going and building my own database infrastructure and doing my own data modeling, let me just pull in the set of models from FHIR. And that's something that I'm seeing more and more as a very quick way for app developers to get started. We're also seeing those models being used in machine learning contexts to say, I want to train a machine learning model to take in various healthcare data and make certain predictions. And even if the source healthcare data are not natively represented in FHIR, it's often the case that there's an advantage to doing that translation so that you've got consistent data coming into your models. So those are some places in which FHIR is taking up an important role beyond just communicating data between systems. And I think those are all really good and important. I'll say from the government perspective, or from the sort of national interoperability perspective, one of the key challenges with FHIR, of course, is figuring out beyond the sort of rough scaffold of these data models, what are the detailed profiles that we're going to use to describe exactly how we capture medical observations in the context of a given geography or in the context of a given clinical specialty. FHIR is very open-ended, and it's entirely possible to have many different systems that all use FHIR, but aren't deeply interoperable with each other. So it's, again, always really important to set out initially and define, what are the problems that you want to solve. And if you're building a specialty network of ophthalmology care, and you happen to be using FHIR to bring together different health data systems into a registry, which is an example I saw recently, you need to be really specific about the sets of observations that you need in the ophthalmology domain to make sure that you've got consistent data coming in from these different places. So it's a great foundational standard. It's being used in ways that go even beyond some of the original design intent, but it also requires a fair amount of care and evaluation. And I should say, it's not the right tool for every job. I think FHIR is a tool that deserves evaluation for almost any clinical project that you're thinking about taking on. But the result of that evaluation might be, yes, let's move forward, or no, there's other considerations, and sometimes there's reasons to do something that's a little bit less abstract if you've got a very narrow problem to solve.
Okay, you mentioned a really good point at the beginning of your answer that Korean government, we are thinking about and considering to build something like Korean core profiles or implementation guide, something like US core implementation guide. We don't have something like that, but we are also thinking about to what extent would be a government's role. So we may develop something like KR core implementation guide. Then what's next? Do we necessarily have to build all other types of standard core profiles, or let some of those to things, domain expert or industries? That's quite often centered about.
Yeah, and I think that in general, a light touch is probably best here. So particularly if the national infrastructure already mandates the use of certain kinds of terminologies or data structures, then absolutely, by all means, describe those in FHIR profiles to make sure everyone's on the same page and it makes validation a little bit easier. But you can go deeper and deeper, almost without limit. And I think the return on the investment there shrinks and might even become negative if it sort of slows down the amount of innovation or other exploration that people are going to do.
Okay, yep. Thanks for the insight. Let's move on to the next question. It's more related to government program initiative, but let me just continue. It's about alignment with EHR Certification Program. So this agency, KHIS, we started a Korean version of meaningful use program just 2 years ago, which is similar to meaningful use in US, but a bit different because at the time of we started this project, not like meaningful use, most of Korean hospitals, they already had EMR systems. So we're not starting from scratch, but we also found we are aware that that a hospital implemented and adopted EHR doesn't necessarily mean that all of those data are interoperable or they need all other benefits of those implementation of EHR brought there, which means that there are still issues of lack of standardization, lack of interoperability, and codes are still localized, and there are missing safety related functional or things like that. But generally speaking, our problem is that we have to do things what US have done over the last 15 years in a shorter period of 3 to 5 years. And while we are doing on hand EHR certification program, and the other hand, we are working on interoperability project. When we have to align these two, that we want align interoperability as part of EHR certification program, but we are not quite sure that how we can do that well. And we would like to learn from lessons learned and experience from the US.
Yeah, I mean, these are real challenges. And looking back at the history of how the meaningful use and certification programs have rolled out in the US, I mean, it hasn't been necessarily linear and consistent progress. I think we've tried several different things along the way, from the idea of promoting patient portals from each provider to the idea of supporting secure email that patients could trigger the transmission of between different systems, to the idea of APIs where personal health apps can connect to records. And we've generally taken one set of approaches for consumer access, patients to get their own records, and a totally different set of approaches, different technology, different trust fabric for business to business exchange, helping providers share data across different health systems. And that creates a lot of challenges. Just the fact that there's such different infrastructure for those two use cases, I'd say that's been a pain point. I will also say, one consistent theme has been, when do you announce your intention to industry and say, here's the problems that we need solved, go and solve them, versus when do you say, here's a set of specific standards that I need you to adopt, here's your time frame for demonstrating compatibility. And I would say there's risks on both sides. One of the things that worked best in the sort of history of the meaningful use era was, right before, around the time of meaningful use stage 3, where we had functional requirements that said you need an API for every patient to be able to access certain types of data from their record. Didn't lay out the standards, but did say, we're thinking about raising the bar in the future. We're thinking about adopting FHIR. And that was a strong signal to industry to go and develop the detailed guidance without imposing it too early. And I think sometimes that's enough. And as much as you can sort of play that game, you really avoid prematurely making a set of standards adoption decisions that could lock you in. One more quick comment here, just in terms of the overall way that our certification programs are designed. We have some requirements that are very specific and narrow. So things like access to a US core data set following these standards. And that's great to sort of create a common bar that everybody can provide access to medications and allergies and labs following those standards. And then on the other side of the equation, we have some requirements that are much less detailed on the technical front, but broader in terms of the data set. So we have this concept of a full EHI export. All the electronic health information, no matter whether it's standardized or not, some way that every certified system needs to be able to just spit it out in a set of files. And you can use whatever format you want as long as you document it. And I think that both of those things are important. The narrow and limited and consistent, and then the broad backstop that means that information doesn't get stuck or lost inside of these systems.
Okay. Oh, that's good lessons and learned. Yeah. Okay, let me just move on to the next question. International interoperability. So we have interest in sharing data across countries and even to make systems even becoming interoperable across countries. But realistically, there are obviously many barriers in terms of I didn't put here, but language is probably first, and the culture, then technology, and when the time comes to share and exchange the data, then even things like data privacy rules, this should be shared and cannot be shared, and this is consented or not, and this rule applies to this country this way and the other way against this country, and lack of standardization, of course. But we have interest in, and there's one more question that pretty related to this question, but in the time of pandemic, and things like sharing, COVID-19 vaccination record across countries and diagnostic information, things like that, will really drive this international interoperability, we would imagine. So what do you think the biggest hurdles of international interoperability for now in general, then how can we overcome them?
So, I mean, one of the challenges is just kind of workflow and data flow. So, even within the US, it's hard enough to say, how do I get data from point A to point B? There's different networks and stories for that. Dramatically more complicated when you talk about moving data across totally different policy and technology regimes. For me, the sort of most obvious and best solution there is workflows that rely on the individual subjects of care, healthcare consumers and patients who maybe they're getting care while they're traveling, or maybe they're traveling for the purpose of getting care. But empowering those individuals to bring their own records with them is kind of the best common denominator that works across those borders. There's often a challenge of trust, or there can be. So if I'm bringing my own records, from one place to another, and the organization that created these records is not really known at my destination. I mean, maybe the source is my local health clinic here in Madison, Wisconsin, and nobody's ever heard of Wisconsin. What does it mean? Does somebody on the other side sort of believe that my medical history is complete and accurate? We often have this kind of social trust fabric that can be missing across these borders. We have some technical solutions there, things like digital signatures, so you can tell the information is authentic. But in a cultural context where you really don't know the organization that originated it, verifying a digital signature doesn't mean too much for you. And so you have to figure out sort of what you want out of that trust relationship. I won't comment much on the language aspect, except to say that in the general case, machine and automated translation of narrative text has gotten pretty good. This is not to say that it's a great general approach to medical data out of the box today, but that's maybe the area that I'd be least worried about in this whole stack.
Especially as far as it's structured and coded.
Exactly right. And that's sort of the last quick point, which is, what about the data models? Not everything in my record is going to be captured in a way that's going to be easily understood everywhere in the world, but there are efforts underway like the International Patient Summary and the International Patient Access Profiles to say, let's at least pick out the most important aspects of a record that are the most well standardized and agree on a core set of profiles there. And I think that's really important in terms of bang for the buck with international sharing of records.
Okay, yep, that's great answer. Thank you. Let's move on to the final question: infectious disease and interoperability. I personally realized this issue. I'm actually in Korea, although my background is my best is always Arches National Park in Utah. But we have some what makes me realize the problem is that I'm fully vaccinated, and I have the CDC's paper card, but it's not electronic. Although I have in my iPhone, my Apple Health showing that when I was first dose and second dose and what types of vaccine dose was, and as well as my COVID-19 negative testing data. And that makes me really feel like then I have all the data. I can show you either the paper or my iPhone or somewhere in the database in the back end. But how these Korean people, especially in the embassy or the immigration office, trust me or trust this data to what level and where the way of technology or system wise or things like that. And how do we make a good agree on that between not only about just Korea and US, but between the multiple countries in the future. So that's really interesting, question and challenging things and problem to solve. But the question is that we've seen that, during the pandemic, interoperability has been contributing to address the issues like standardization of data of diagnostics and vaccination record and self-monitoring and mobile apps for that and public health and population health monitoring, surveillance, things like that. In the future, what would be the most important role of interoperability to deal with COVID-19 because it is still ongoing? And you're a physician and you know that, but there may be possible infectious disease come on maybe next to COVID-19. So what do you think about this?
Yeah, I mean, so this was certainly an eye-opening experience for me throughout the pandemic response. I've been doing a lot of work on data standards and interoperability as part of the response. I mean, so first of all, there's just an overarching need for public health surveillance and understanding the facts on the ground. And at least in the US, on the way into the COVID-19 pandemic, we didn't have good infrastructure for rolling up summer information across hospitals. How busy are the hospitals? How many free beds? How many ventilators? What's the capacity? All those kinds of questions. We didn't have any automated infrastructure for it, or not much at all. And so it boiled down to basically spreadsheets that an administrator at every hospital was asked to fill out every day on top of everything else that they were doing. That's where we found ourselves at the beginning. And so partly, of course, the urgent need spurs new development and new work. It can be a great forcing function to get things done quickly. Okay. So the work that I've done on the smart health cards specifications, for example, you mentioned the integration with Apple Health. That's been a really strong example where we had a very narrow piece of data like COVID-19 lab results and immunizations. And we said, can we use FHIR? Can we use a set of data signature standards? Can we build a community trust fabric to say who are the different issuers, the vaccine sites and the pharmacies and the public health organizations that are giving vaccines? And let's just solve that very small problem end to end. From trust to data formats to the workflow for sharing a QR code into a mobile app. And we saw adoption of those technologies move very quickly. And so that's an example of some place where the pandemic response can really help galvanize a consistent adoption. But at the same time, especially for problems that are a little bigger and more challenging, broader problems, trying to scramble to solve them in the context of a pandemic can be very painful. And so like the hospital data reporting story, for example, trying to build a good general purpose infrastructure quickly in an interoperable and future-proofed way, like that's a very big challenge to try to scramble on during the pandemic. Okay. So that preparedness question is one of the key challenges. Like how do you foresee the needs that are going to come ahead of time so you're not scrambling in the moment?
Yep. Okay. We're on time. Let's move on to the last slide. And so I mentioned that these 5 questions are huge and open questions, but as an interoperability expert, would you think that there's any important aspect of or questions about interoperability you think but has been missing in this question? Or overall, I think you covered a lot of your information and your insight and knowledge from your answer. But is there anything you'd like to highlight from there that you'd like to do that in the last minute?
Yeah, so one thing that I only just touched on that I might draw stronger attention to is the role of individual consumer informedness and consent and authorization in all of these health data flows. So there's an aspect of privacy and transparency to this. In other words, how do I know how my information are being used? How do I have a stake in helping shape those decisions? And I'll say that one of the strongest things that can be done here is just to give individuals a role in that process. So instead of establishing a set of data sharing practices where parties on one end of the exchange and the other end of the exchange just sort of talk to each other, involve the consumer in the loop. So maybe the first time a data exchange is going to happen, maybe that's something where the consumer helps make that introduction and approve of it. Send what's sometimes called a consent receipt, or evidence that data is moving, back to the consumer, so they stay on top of it and they understand where their information is going and how it's being used. We've seen some very interesting approaches to this being taken, for example, in India as part of their health stack initiative, where individual consumers get to sort of define those consent policies using an identity that they choose to make decisions about how and where their data should flow. And I think those are all really good themes. And the one sort of related component there is, I mentioned in the US, we have these totally different models for business to business sharing versus sharing with a consumer. And my personal perspective is those things should be unified, and we should have one framework where consumers play a real and direct role in the process. And I think that's especially possible in places where there's a fairly high level of technology adoption and a fairly high level of technology literacy.
Okay, yeah, that's a great point. Thank you.